Good morning, everyone. We've got something like 80 participants joining us today. It's an extremely good turnout. Now, unfortunately, you can only see our beautiful faces, so we can't see you. We are recording this event today. For anybody that can't attend or who misses anything because the doorbell rings, their shopping gets delivered, or whatever that might be. Thank you all so much for joining us. You've all been invited because you've so kindly supported the hospital at some point over the last few months and made an enormous difference. And hopefully at the end of this event, you'll have a really clear idea about just what difference that support has meant to our colleagues in the hospital. I've got the pleasure of handing over to our host today, Rees, who is an ACT trustee and vice chair, who will in turn introduce our speakers. I hope you really enjoy it. I hope you find it interesting, and I certainly will do myself. Chris, without further ado.
Very good. Thank you very much, Paul, and a very warm welcome to everyone on the webinar this morning. We're absolutely delighted that you're joining us. So it's a great pleasure for me to introduce our guests. And our guests this morning are Jane Olds, ICU Matron. So give us a wave, Jane. That's right, thank you. And then Charlotte Summers, an ICU consultant. So Charlotte this morning is the on-call consultant. So she joined us 5 minutes ago, and we're hoping now that nothing dramatic happens in the next hour, so that we've got her time all the way through. And it's also Charlotte's first day back from holiday, so very warm welcome back. So our two guests, thank you once again. As Paul said, my name is Rees. I'm an ACT trustee, and it's my pleasure and privilege to be hosting the meeting this morning. Paul said we have over 80 people this morning on the webinar, which is an extraordinary level of support, and I think it shows our incredible passion for the hospital. We will, as Paul said, record the event this morning for those who physically can't be with us. So on behalf of the hospital and on behalf of ACT, a huge thank you to all of our supporters for the incredible response to our appeal when the COVID crisis began. We have received over £1.2 million in donations, which is absolutely extraordinary. And that money has been used for everything, right through from cutting edge technology at the one end to deal with how we deal with COVID going forwards, right through to the patient-facing work that we do on the wards and in the ICU units. So the money has been well used, and it will continue to be well used going forwards. So if I just talk very briefly about housekeeping for the event, as I said, we will be recording the event. We have got some pre-submitted questions from people who are joining us this morning, which I'll share then with the team after the event. And if you want to ask questions during the presentations, you'll see on your Zoom screens that there is a Q&A function at the bottom. So if you hover your mouse around or put your finger on the bottom of your screens, there's a Q&A function there, and we can pick those questions up actually during the seminar. And if we do run over time and we can't get through all the questions at the end, then what we'll do is we'll get the questions answered and we'll share the answers with everyone that joined us this morning. So that covers all the housekeeping. Once again, a huge thank you to Jane and to Charlotte for being with us this morning. And it's my great pleasure now to hand over to Charlotte, and she will talk about her overview of dealing with the crisis in the ICU unit. So thank you. Thanks, Charlotte.
Thank you, Paul. So my COVID journey, as it were, actually began at the very beginning of January this year. So the first work engagement that I had in January 2020 was I had a meeting at the Wellcome Trust, because I'm an academic intensive care physician, with Jeremy Farrer, who's the head of the Wellcome Trust, who is a specialist in viral pathogens. And actually, we spent most of that meeting not talking about what we'd planned to talk about, but a lot of it talking about how we'd been both watching over the Christmas period what was coming out of Wuhan, and how it had all the flags about the things that we ought to be concerned about. Because even at that point, it looks like people were potentially transmitting the virus without being symptomatic, which is the nightmare scenario for a pandemic. When we'd had the previous SARS one about 10 years ago, you only transmitted the virus when you had symptoms. And the thing that we'd all lived in fear of was asymptomatic transmission. And then we're watching and watching and watching over the next few weeks and getting increasingly concerned. And then by the end of January, beginning of February, Addenbrooke's trust had started putting a group of people together to think about how we were going to manage if this really did get out of hand. And by probably the first week in February, we were meeting 3 times a week, which rapidly increased to daily by the middle of February. But as an ICU, our first collective meeting about it was actually on the 12th of February. We had a multidisciplinary meeting where we had consultants and nursing staff and physios and the virology team and the infection control team all get together to talk about what was known about this new virus and the best ways of clinically handling it, and to start thinking about what it was we would need to do to cope. And as I say, we've been having these daily meetings as a trust too. And then things sort of continued apace from there. The organisation had several kind of war games where we looked at the scenarios because nothing was happening. There were very few cases in the UK at this point, none in the east of England. In fact, we didn't get any in the east of England until nearly April. So this was February, and we were still planning for what we were going to do if it happened at that point. So we did a lot of pandemic planning exercises. We started thinking about what equipment we might need, what care protocols we might need. So by the beginning of March, actually for the 3rd of March, we had a fully drafted plan as to how we were going to increase critical care capacity and how we were going to manage these cases in terms of the clinical management, based on everything we knew that was published in the literature and from colleagues that were managing. And it continued kind of a pace and escalating from there. Our first cases came in towards the latter half of March, with the actual peak surge for the whole UK being simultaneous in the 2nd week in April. We mobilised staff from across the hospital. We mobilised staff, particularly junior doctors, but also some consultants who are normally out in research, so doing research training posts, came back to the NHS full time, of which I am one, but there were many, many others. Lots of the people who would normally do consultant practice between anaesthesia in the operating theatres and the ICU all transferred to being full-time ICU. We completely changed all of our working shifts as doctors, and the nurses had to change too. And I'll let Jane talk about that side of things. We all had to learn and teach a huge number of people things like it's called donning and doffing, but putting on all of the personal protective equipment and taking it off is a bit of a palaver, which you may have seen on the news, and take some practice to do it so that you can do it scrupulously and not virally contaminate yourself or anybody else. And work out how we were going to do some of the procedures that we do commonly whilst wearing all of that garb, because actually it's a very different thing when you've got a hat, a visor, full face mask, and double gloves and things on that you wouldn't normally wear. You become a bit more cumbersome doing some of the more technical aspects of the job, and that takes careful practice too. And all alongside this, we had the anxiety that I think is acceptable and normal for a bunch of people who have got something coming towards them, but you don't quite know what it's really going to be like, because this is a new virus. No one's ever seen this disease before, and you don't know how bad it's going to be. And now it seems like it wasn't as bad as it could have been, but at the time in March, don't forget, the conversations were all very much about how the entire United Kingdom was going to run out of mechanical ventilators and ICU beds by the 30th of March. That was what the government expected. That's what we were being told to expect and to plan for. And every ICU in the country was asked to come up with 4 times their normal bed footprint, which is an enormous ask. But that's what we were expecting to come towards us in a tidal wave. And for some places, that's what arrived. It wasn't quite that bad in Cambridge, although we were definitely stretched. But that sort of anxiety of the unknown was very much present. in April we hit our peak, and actually the way we coped with that is that we turned some beds that we would normally use for non-ventilated critical care into ventilated critical care beds, and we opened up new beds on a ward called J3 that was our surge ICU. So actually we never had not enough critical care beds at any point at Addenbrooke's, because we'd spent all that time carefully planning beforehand. We were able to keep in front of the wave of admissions that came to us and to support the trusts around us. So there's no doubt that some of the smaller district general hospitals in the east of England were absolutely besieged, and we were able to take some of the pressure off of them by saying, transfer us your patients, because we know that load levelling is a really important way of making sure everyone gets access to good quality intensive care, rather than us having capacity and the hospital next door to us being absolutely overwhelmed. And then after the kind of middle of April, things started very, very gradually in terms of COVID to decline, such that we finally became COVID free at the end of June, beginning of July. But I think the thing to say is that whilst the COVID critical care work has gone away, actually, as Jane and I both know today, because we're both clinical, the critical care demand has not gone away. We've exchanged what was COVID ICU, and we just had one condition overwhelming us for April, May, June. All of that work has been replaced by a whole host of other people who are unwell, and it's undoubtedly the case that there were people who stayed at home during the pandemic and who are presenting later and less well than they would have done normally. So we're still not actually back into the bed footprint that we had beforehand for ICU, not because of COVID, but because we've got people who are unwell and need our services. So we're running at a sustained higher level than we were before, and have made long-term plans as a trust to be able to do that over the next 18 months, 2 years, to support this workload, catching up with the elective surgical workload, but also should there be any subsequent waves of COVID. And I think that's probably where I'll stop and let Jane talk.
Excellent. Thank you so much, Charlotte. Fascinating. So, Jane.
Hello there, everybody, and thank you very much for giving us this opportunity to talk to you all and say a massive thank you. Yeah, I can only echo all the things Charlotte said. We've had the most incredible time that I don't think any of us in our careers expected to have. Yeah, I was with Charlotte for those meetings early on when we did lots and lots of planning, and it was with lots of anxiety and almost disbelief as to whether this pandemic wave was coming our way, and were we doing all this planning, and was it needed, and you know, what was going to happen. That I think was one of the hardest things to cope with. I think it's almost like when you're preparing for an exam, that anxiety and revision is really, really hard, and you just want to get on and do it. And that was the feeling. We just wanted to, what does COVID-19 involve? What patients are we going to get? And what's going to happen? And that unknown was really, really difficult to manage at the time. From a nursing point of view, we knew we started with 32 level 3 beds, which are the critical care beds with the ventilators and the breathing machines and things. And we made a plan, like Charlotte said, to be able to quadruple that capacity. And that involves a huge amount of staff to be able to do that safely, which we didn't have. We didn't have those trained staff. Intensivists and critical care nurses are very, very precious commodities across the whole world. So what we did was ask for volunteers across the trust from the nursing teams, and we got 600 nurses to say that they would come and support us during the pandemic. And we ran a 2-day course for them to do some training and get the very much basics to be able to come and work alongside us and support us. So that a critical care nurse might be looking after, rather than one patient, they might be, for us, looking up to 3 patients, but they would have those ward nurses that have had a tiny weeny little bit of training to be able to do that and help us. We also involved the physio team, so 25 physios that normally work across the trust came and worked with us in critical care alongside us in the bed space with the nurses, doing sort of workloads that they're not used to doing, but they were absolutely amazing. So we all of a sudden, as we cranked up and got very, very busy into April, and we went up from 32 level 3 beds, we ended up managing 71 beds in the end, which was massive. We had all these staff coming and working with us. To manage that, we had lots of extra equipment that we'd never used before. We were all used to using various pumps and machines, but we had different pumps and machines as well as everything else. So the training impact on everybody was massive, and we were really doing that on a day-by-day basis. The other thing that I think Charlotte will probably echo is that as information was coming out, we were deciding one day that we thought one way was the best way of doing it. And then we were hearing from all over the world and from our colleagues across the country that actually there were different ways. And so the following day, we were changing everything all over again to make sure we were doing the absolute best we could for our patients. But that is very, very stressful to try and make sure we get that communication right. And we were doing it was very, very difficult. And that change factor was something that staff struggled with. The basics as far as us putting on all our PPE and taking it all off was really, really important. And one of the little things that I hadn't considered was that as we used the FFP big face masks, the pandemic stock that the country had was all sorts of different masks. So I went into it feeling very confident. I had more than 85% of my staff trained on 3 different masks and everything else. But a month into the pandemic, we all of a sudden had completely different shapes and sizes of masks. And I then, as well as my own staff, I had 600 other staff that I had to make sure that they were all being mask fit tested and everything else. And they were things I'd never sort of thought about and considered that might happen. And the anxiety that went alongside that to make sure we had everybody safe so that they could go into these areas and sort of work safely was hard. Like Charlotte said, for all of us, wearing gowns, 2 sets of gloves, a big mask which absolutely muffles your voice, so therefore makes it very difficult to hear people, a visor which does steam up and everything else and cause problems, and also your vision isn't as clear as it normally is, was very, very hard. All your senses being slightly numbed just when somebody is very, very critically ill was very difficult. We obviously, staff were in PPE. We were trying to desperately preserve the PPE stock because, as we all knew, listening to the news headlines and talking within the trust, we were some days just a few days away from not having enough stock. So we didn't want people to take their PPE off and come out of the areas too often. But equally, people needed to have a break. They needed to go to the loo. So it was a really fine balance as to what we did to manage that. And that's, you know, something even now, because we're still wearing full PPE, because COVID very much is still around within critical care, is something we're trying to do. With the heat wave we've been having, although most of our areas we do have air conditioning, it's air conditioned as far as to British normal temperatures. So, you know, the staff have been coping and struggling with the heat, and that has been hard, very, very hard at times. But actually, the whole team and the whole team within the hospital that supported us have been amazing. They have been brave and they have just got on with it, which has been great. And I'm getting choked up now because one of the hardest things we had to do was not have any visitors at all in critical care. And I think all the staff will agree. We work alongside all our relatives, and not being able to do that, and only being able to do that slightly later on as we use technology, was the toughest thing to do when people are so poorly. But the support we've had from the general public and from our relatives has made that possible and has been fabulous. I'm going to stop there and then maybe hand over if Charlotte has anything to add from what I've been saying. And then maybe some of the questions can pad things out a little bit.
That's fantastic, Jane and Charlotte. And thank you so much for sharing the extraordinary insights. Before we talk about the impact that the support gave, as I mentioned earlier, over £1.2 million committed and donated in support during the crisis. And in terms of how we work as a charity, normally we have a process where we have a charitable expenditure committee to make sure that money is being prudently allocated and spent. That normally meets not very often, and clearly as the crisis began to unfold, we had to change the way that we worked. So we went from meeting, I think originally quarterly, to meeting weekly, and then some weeks meeting even more often than that to approve expenditure, to make sure that the money got to the front line where it was needed very quickly. So that worked really well. So a question then probably for Jane and for Charlotte. We were able to respond in terms of the money that was raised from our fantastic supporters to get it to the front line. Can you give us some examples of where the money was used and what you wanted that we were able to support you with as a support charity?
Jane, do you want to?
Yeah, I can start. So at the beginning when we were doing the planning, ACT had kindly a few years ago supported our plans to have psychologists in critical care, and they funded that for us for 18 months while we did some work. And then because it was so successful, that was then accepted that the Trust and NHS England agreed that it was something that needed to carry on. So thanks to the ACT support a few years ago, we already had psychologists in critical care that at that point, they were working with our patients as to how they manage when they're getting better and waking up in critical care. From our relatives' point of view, how they cope with having somebody so critically ill and the impact that's going to have on their lives and the anxiety while they're so ill. And from a staff point of view, as to the different things that staff cope with from a burnout point of view or a stressful point of view, or the difficult sort of very sad cases that we do deal with, unfortunately, on a day-to-day basis. What we were able to do right at the beginning of this is with the psychologist decide that we would fully start and concentrate on our staff and looking after our staff and the anxieties that were going on. And that was incredible to be able to sit down, well, before it all started, with the psychologist and say, this is what we're just going to redirect this at the moment and support staff. They straight away contacted ACT and made sure that they had tea and coffee facilities and everything else so that they could just sit down with teams of staff. We could make sure we gave everybody a hot or cold drink and hydrated them, and they had somebody that they could talk to. So Monday to Friday, 9 to 5, there was always somebody around or somebody on the end of a telephone for them to make contact with. Because staff were, as well as coping with what was going on at work, they had all their family anxieties and everything else that we were all coping with. And obviously that, for different people at different times, was really, really difficult. So that was incredible, and that made such a difference to our staff.
I think I would just interject here and say the difference between one of the ways that we were able to cope at CUH compared to some other institutions is exactly that. The Intensive Care Society are having a national appeal to try and put that kind of support into every ICU, but thanks to ACT, we already had it. So when we were dealing with the anxiety of all having things at home, and for me, I have a husband who's high risk for COVID, everybody else has their own different things to carry. The burden was both inside and outside work, and having a really clear psychological well-being plan for all of our staff supported so strongly by ACT was amazing.
I agree.
Yeah. And I think then, obviously from our relatives' point of view, the technology we were able to put in place. So we had some technology anyway, and we had some iPads that we've been using for the My ICU voice, which has been supported from ACT. But obviously, all of a sudden now, we wanted to do things which we've never done in critical care. We've never Skyped people. There's always been confidentiality issues and everything else, but we were in unprecedented times. And ACT to be able to straight away get iPads to us so that we could do that communication with our relatives was amazing. And obviously how we can then go forward now, we've got more iPads and we're getting more and more au fait every day with technology, such as meetings as today, that it gives us that, you know, more and more opportunity. We can use now the My ICU voice a little bit more. That's just learning and changing as we learn and change things, which is brilliant. We also, just like the rest of the country, we had staff that couldn't come into work because they were shielding at home because they had various health issues, or they had very high risk people within their household. So we were able to set up sort of an at-home relatives communication team that was a mixture generally of reasonably senior nurses, and they very quickly got very up to speed with the technology. And so we're able to link in with our relatives, speak to them over the telephone, teach them how to use Skype and everything else. And so that then they were able to access the hospital, and we were able to do that. And that was all of us sort of changing and learning. 1 week we'd do it one way, and then we'd tweak it a little bit and do it slightly differently. And I think we've all, how we'll communicate in the future will be better. You know, we've learnt different things we can do, and that's great. And that is all down to this technology that we've been able to use, which is
wonderful. Wonderful. I think what's extraordinary, as Charlotte said, is the speed with which we were able to prepare for this. And Addenbrooke's was absolutely in front all the time, and proved once again to be an extraordinary centre of excellence, which is wonderful. And then also the way we were able to translate that preparedness into looking after the patients on the ward, and the very human side then of the story, and the insights into the emotional stresses, not just by the COVID, but by the normal ways that we support our patients with their loved ones being with them, and that's suddenly coming to an end. So, no, brilliant. Thank you so much. Very good. So I've been sent a list of pre-submitted questions, and the questions are great. They cover a broad landscape of different inquiries. And I'll start off with one which you've sort of answered, and that is, how many breaks do you get during a shift on ICU?
Do you want me to, Charlotte, do you want to go?
Yes, please. I'll tell you what, if we kick off with Jane,
yeah, okay.
And then we'll go to Charlotte.
Yeah. So the nursing team generally do 12-hour shifts. So it's sort of a 12.5-hour day shift and a 12.5-hour night shift. So there's a little bit of overlap either side. In a normal times, the staff would have, during the day, they'd have a quick 15-minute break in the morning, sort of a breakfast break. They'd have a half-an-hour lunch break, and then a quick 15-minute break sort of later on in the afternoon, just for a quick cup of tea, something like that. Overnight, they'd have an early break where they generally have their dinner, and then they'd have an hour break at some point during the night. And they all sort of sit with the European Working Time Directive and everything else. But normally, when you're not wearing full PPE, if you just need to nip to the loo, you would just say to the person working next to you, I'm just going to be 2 minutes, I'm going to the loo, and off you'd go and come back again. And obviously that wasn't at all possible. So the practicalities of that, you know, for any of us, I think to start with, staff were quite dehydrated because we were all very aware, oh my goodness, I don't want to drink too much because, you know, I might have to go to the loo. And the critical care staff were very stretched anyway, so it wasn't as easy to relieve people for breaks. I think we got better anyway, and what we were trying to do from initially making sure everybody had a break every 4 to 6 hours, we very much shortened that, and it was more sort of every 3 to 4 hours having a break. And we gave people the opportunity, we extended break time a little bit, because taking the PPE off and then putting it back on again took time. And obviously we wanted people to actually sit down at least for 15 minutes and get a drink. And what we did was give people the opportunity to have shorter, more frequent breaks. We all mucked in. The medical team, when they were on overnight, you know, when the nurses were having breaks, and definitely when the senior nurse covering the area were having breaks, the medical staff made sure they put on full PPE and they went into the area and supported the nursing team. So it was a full multidisciplinary team approach to make sure we all looked after each other, which I think just made it all possible and gave us all that morale boost that we needed, that we really were all in it together.
Very good. Charlotte?
So the medical day works slightly differently to the nursing day, but we changed for COVID completely our work schedules anyway. We went both for junior medical staff and the consultants to 13-hour days or nights. So we'd have an hour handover, but 12-hour clinical shifts in the midst of that. Slightly differently to nurses, doctors don't have set break requirements. You take them when things kind of ebb and flow during the day, and so some days there was some ebb and you could have some breaks, and other days not so much. It kind of was more dictated by what was happening, but all the things that Jane has just highlighted about getting out of PPE to have a drink, everyone being dehydrated, tired and hungry, definitely held true for us as well.
Very good, thank you. And the next question, this is for Jane, and this one comes with a kiss from the questioner. Are you still using the ice-cold pink swabbing sticks to moisten ICU patients' mouths? 3 exclamation marks, absolute heaven.
We most definitely are, yes. Really interesting because we've sort of touched on it a little bit. The My ICU voice, one of the biggest things we learned early on were patients were telling us when they couldn't talk to us, they were hitting the button saying, my mouth is dry, my mouth is dry. And so what we found for a lot of patients, although we were using the pink swabs with lovely cold water, and you could just, the bliss on their faces, it's such a lovely thing to do because it's instant gratification for the person doing it. But it didn't last. What was happening is they, 5 minutes later, their mouth was still feeling dry. So we now use some special gel that moistens people's mouths and stays more moist. So we use the pink swabs as well, but because of what we've learned, which we just weren't aware of at all, we thought we were fixing it constantly. We've added some extra things in, which, patients are saying is even better.
Very good, thank you very much. And the next question then, this comes from somebody who says, I just wanted to say a massive thank you to all the ICU staff. And my partner was in Addenbrooke for a month with COVID-19 and you saved his life. So thank you from the bottom of my heart. You all do such amazing work, which that's a fantastic thing. And the question then is, how difficult was it initially to treat a virus that you didn't know much about? So Charlotte, I think we'll ask you to answer this.
It's difficult because you're taking your best guess as to what's right. We spent a lot of time looking at what's known about respiratory viruses and the type of ones that cause pandemics. So obviously we've had flu and the SARS-1 virus before, and we knew quite a lot about that, and also the coronavirus MERS. So I'd been involved in the WHO response to MERS previously and helped write the clinical guidelines for how you manage that. And there are other people in the organisation who'd been involved in various different aspects of pandemic planning before. So we took our best guess, and as Jane highlighted, as things evolved and became clear, we were changing and changing and changing. And I think it's a sign of the kind of organisation we are, that we're flexible enough to do it. But we'd be fibbing if we didn't tell you that it's incredibly hard, because you've not just got to get one person doing it, you've got to get the whole team doing it. And we had 600 extra staff members, the total staff across critical care to run 71, and that was just the number of beds we had open. We had a plan actually and the equipment there to have 89 beds open, and everybody trained up to staff those if we needed them. Getting everybody changing what they're doing and understanding what today's plan is not a small undertaking. But I think we were able to do that. And we are a science-based organisation. One of the joys of CUH is that we've got clinical academics, basic science academics, and clinicians all working alongside each other on one team. So the very best science feeds into the bedside, and the bedside feeds into the very best science. And at times, like a COVID pandemic, it's absolutely the time when that pays dividends beyond measure, I would say.
And then a question, and again probably for you, Charlotte, and you touched on it briefly. How long was it from the initial cases being identified to you being effectively a full-blown COVID unit? If you take us back to that part of your presentation.
So the initial cases in the east of England actually didn't come until the later part of March. And there were other institutions in the east of England that had cases before us. So places like Watford and Luton and Southend that were on the kind of London periphery had cases. So there was a period of time where everything was starting to build up in London, and you could see it edging towards us. If you had we had a colour-coded map as a region as to who had how many cases, and you could see the kind of red bit in London and then an amber halo around it. And we were green, but the amber was getting closer. And then our peak was the second week in April. And actually the peak nationally was the same for absolutely everybody. Although the start and the ramp up was very different in different regions, everybody had the same 2-week peak. And so actually our peak came pretty quickly, but there was a long phase where it hadn't arrived with us, but we knew it was coming.
And then a question for Jane, and you covered it in part, but there's an extra part of the question here which is being asked. Were staff members redeployed from different areas of the hospital? You talked about the training, what the training was like. The question then, how will it be for those staff as they begin to go back to their normal jobs?
So some staff probably from about July, when things were starting to settle down a little bit more, have gone back to their different areas. We obviously had staff that were research nurses, specialist nurses in other areas, and so as we tried to get back into doing our normal daily business, it was really important. Some of the specialist nurses, they were the only nurse in their area. So although in their career history they'd worked in critical care, so they were gold dust as far as we were concerned, they were also gold dust to their normal day job. So, you know, as much as we were sort of trying to cling on to them for as long as we could, they had to go back. What we've done for those staff, because actually most of them have we've done lots of surveys and asked them for their reflections and reviews. They actually really enjoyed feeling that they could make a difference and come and help. And so we're giving them the opportunities to come back and do keep in touch days, so that they maintain those skills. And that's also one of the things we're planning, that if we do have a second wave and anything else happens, that we have staff that are all ready to come back and join us. What's really interesting, a lot of the staff that worked on the wards and have never worked in critical care before and came and joined us when I would say the hardest time to come into critical care, not as amazing and brilliant and fabulous as it normally is, have loved it, absolutely loved it. And we're doing a big recruitment drive at the moment because we have expanded on the back of everything that's happened for COVID, and to make us ready for anything that might come in the future. And we are just having an incredible response from these staff applying for our jobs and wanting to come and join us. And so they are actually now here with us permanently, which is amazing. And we're really, really happy about.
Wonderful. Okay, so we've got some live questions now have come in on the Q&A function on the webinar. And there's one here, and we talked about the initial panic over when ventilator numbers was assuaged by a different treatment emerging as a better approach. What other aspects of your approach changed markedly as a result of you gaining experience and understanding as you went along? So Charlotte, do you want to lead on this one?
I think I'd say two things actually. Firstly, I might say that I'm not sure I necessarily agree with the question. The idea that the non-invasive ventilation is superior to mechanical ventilation, we don't know. There was a lot of publicity around it, and then there was lots of stuff in the papers, but actually there is no published data to support that point of view. There is a really big national trial called Recovery RS going on at the moment across most hospitals in the NHS that have acute patients, trying to answer that question. Because although there was lots of publicity in the newspapers saying that the non-invasive types of ventilatory support were better, actually the data is not necessarily supporting that for some of the stuff that's coming out. So I think the jury is out. In terms of ventilators, we did a lot of work on securing ventilators for if we were surging here. I spent many hours working on ventilators, both for our hospital, the region, and the nation. Actually, I was one of the ventilator program managers. I ate, breathed and slept mechanical ventilators and non-invasive ventilators and any other type of machine that might help. As a country, the UK spent a lot of money on securing ventilators to support the NHS and on building them. You can probably see behind me is a ventilator in my office. You might have heard on the news about the rapidly scalable ventilator project that the government launched. That is the very first one off the production line of the Penlon ventilator that came to me for testing, which is kind of my trophy of COVID War One, I guess, sits in my office.
Very good, thank you. And then another question here, and I think we'll ask Jane to answer this. So, astonishing, exclamation mark. What was the main thing that kept you all going?
Our patients.
Yeah.
I think, that's what we're all here for. That everything was going on for the whole world, this was happening. And we very much know, that could be our loved one, it could have been anybody. And, we did it all, for the patients. I think the teamwork and the reason people work in critical care, we are, a very close-knit, multidisciplinary team. We all looked after each other. Everybody put in, 200% and worked really, really hard. So all of those factors, made a massive difference. Morale did ebb and flow. It wasn't, we didn't have all good days. We all had our sort of dark days when we were tired. It felt that it was relentless and everything else. But equally on those days, somebody else was having a better day. So we managed to keep each other going. I think one of the other things to add when Charlotte was talking about ventilators is the other thing we did a lot of was proning patients. And that's probably been talked about quite a lot. And that is sort of, rather than lying on your back, turning somebody over completely so that they're lying on their tummy. And that was one of the probably sort of very much, we do it with patients that do have chest issues normally, but from a COVID-19 point of view, that was something that we found was very successful and, supported our patients during that time. So we, at that point, that takes about 6 or 7 staff to be able to turn over an adult who's completely unconscious and on breathing machines and tubes. So that was one of the things we were doing a lot of. And we had medical students and all sorts of people trained up to come and help us do that and sort of flip everybody over every 12 hours, sort of front to back, front to back. So that was very much something that was happening, and we were learning that from the rest of the world as well.
Thank you. And then a question just come in then, and we'll ask this one to Charlotte. So your early pre-planning was incredible. Has there been an opportunity for sharing the Addenbrooke's good practice with other hospitals and the government?
So yes and yes. So throughout the COVID pandemic period is a health region, so the east of England, we were actually having daily meetings as a critical care network. So I and the other people, all the other hospitals leading their COVID response for critical care, were having a call between 8 and 9 in the morning and for many weeks actually between 4:30 and 5:30 in the afternoon as well, to look at the number of patients, what we were doing, the good clinical practice things that we could share. Was anybody else overburdened? Did we need to arrange transfers? What support did they need with equipment and advice? So a lot of time went into that, kind of locally, clinically managed in the Eastern region. But with the government, yes, because I'm an academic intensive care physician and a specialist in lung injury, which is this area, was involved in writing the national clinical guidelines for how you manage COVID. And you might imagine that people like me have some fairly firm views about how these things should be managed that we may or may not have shared with government at different points during the pandemic. I think that's what I would say.
Very good, thank you. And then a practical question here, a question apart from donations, is there anything else we can all do from home to support the hospital during the COVID pandemic?
Absolutely, yes. Wear your masks, wash your hands and keep going with the social distancing.
Excellent.
That saves all of us.
Yeah, yeah.
Very good. And then another question here, the question is, how do you wind down after a 12-hour shift in such a stressful environment? So Jane, in line with the government's guidelines on alcohol RDA.
I'll adapt my answer slightly. It was very hard, and I think that's one of the things we all, when talking to each other, it was very, very difficult to switch off and sleep and get some rest. I sort of had a pad by my bed because I'd wake up at 2 in the morning and think, oh goodness, I haven't thought about this, and I decided at least if I write it down, hopefully I'll then be able to get back to sleep. And I think that was the sort of thing when we all linked in, which, like Charlotte said, we were all members of numerous WhatsApp groups, sort of as for our local network and nationally and everything else. It was very much a common theme. So we were sharing the different things we were doing. Our psychologists were busy sending out weekly little bulletins with various top tips as far as, you know, do some gentle exercise if you can, make sure you're all eating as healthy as you can, talk to each other. All of the things we could do to try and be as kind as we possibly could to ourselves and to get those breaks. Staff did cancel their annual leave, but equally that was very much, they were able to make that choice, but we would try to look at everybody's rotas really carefully to make sure that people were getting breaks and getting days off, so that we could sort of, everybody was kept going really. And yeah, we just looked after each other. But it wasn't easy. Winding down was hard.
Charlotte, what about you?
Jane's right, winding down was incredibly hard. As I think you mentioned at the beginning of this, I've just had 2 weeks off. That's the first annual leave that actually I'd had since Christmas, because it's been pretty full on. And I found in week 1, it was really quite hard to unwind, because the adrenaline from months of doing it is still there, but by week 2 I was actually managing to sleep and felt a little bit better. Coping, actually, I found that I've done a lot of gardening. ICU, it doesn't have a whole lot of natural daylight, you're inside quite a lot. We've all been sat in front of computer screens for meetings quite a lot. As you'll see, I have a windowless office, and so daylight is not something that I see a whole lot of. So I have spent as much time as I possibly could outside in our garden or at our allotment. I've done more gardening in the last 6 months than I think I might have done in the preceding 40 odd years.
Yeah.
Very good. And then a question again for you, Charlotte. Are you having any success with treating the symptoms of COVID with antiviral drugs or steroids?
So the research studies have shown, and the recovery research trial, which is the big UK trial that's now recruited more than 12,500 patients in the UK, has shown that steroids work and improve the outcomes for people who require oxygen or ventilatory support. As yet, the antiviral therapies, there's one called remdesivir that the clinical evidence from the United States showed that it may, and I use the word may, reduce the time it takes you to get better. So that's become standard of care in the UK. We have that in the hospital and give it when it's required to patients, and alongside the steroids. But what we have done throughout COVID and continue to do is that give every possible opportunity to the patients admitted to this hospital, and particularly the ICU, to be enrolled into research studies. So in the midst of what you have heard us all talk about, actually we managed to enroll 75% of all the patients with COVID who were admitted to ICU in Cambridge into research studies during a pandemic. You know, that's an amazing achievement alongside everything else. But for a virus that we know nothing about, research is the only exit strategy. That's the only way that we find out how to make it go away so that we can all get our lives back.
Fantastic, thank you. And then in terms then of the next question, and let's start here with Jane. Have you had any staff that have contracted COVID during the pandemic on the ICU?
Yes, we have. We don't, obviously, whether they've contracted it here at work or out in the community, because we've had more staff have actually been off with contact. They've had, obviously, their household members with symptoms and things, Early on, when there wasn't so much testing, that was quite tricky. We just had to isolate people anyway. What we're finding now, people are having very similar symptoms, but swabbings are coming back negative. Again, from a research point of view, one of the things we put in very early was that we gave staff the opportunity to be swabbed, and have done regular random swabbing for staff. So we've swabbed sort of everybody working in critical care over a 48-hour period. And from those swabs, we've had nobody has come back with a positive at all, and taken us by surprise, so asymptomatic, which has been really reassuring that the PPE we're using has been effective and that we are using it in the correct way. The highest risk time is when you take it all off, and because you have to do it very carefully, and that's quite tricky. And we spent a lot of time making sure staff were very, very clear about how they did that and how they were washing their hands in between all the different sections. So we're really pleased from the sort of swabbing we've done.
Excellent, thank you.
Yeah.
And then a question then for Charlotte. The question here is, how is the current increase in infections affecting your planning? Are current cases milder, or do you foresee going back into a full critical mode?
So how's that affecting the planning? Actually, it's not affecting the planning at all, because we have a really rock solid plan for surge in critical care to the levels that we did before and a little bit beyond if we need to. And if not for COVID, then for whatever the next pandemic may be. We have worked really hard to get ourselves to the state that whatever comes our way, we will manage. Do I think that there's going to be a second wave? Yes, I think there will be. What does it look like? We don't know as yet. The Academy of Medical Sciences, who were commissioned by the government to have a look with the very best scientists they could find, wrote a really good report about a challenging winter and what's coming, that was publicised quite a lot of the news recently. And the worry is not just about a COVID pandemic for this winter, it's that this COVID surge happened in April, when actually most of the other things that place peak demand on intensive care weren't happening. So now we're going to have a constellation of all the things that we weren't treating during the COVID pandemic that are now needing catching up with: the major elective surgery, the people that stayed at home who have got a little bit sicker, potential rise in COVID cases, but also the winter peak demand from all of the other viruses that circulate and won't have gone away, like influenza and RSV. So we're potentially looking at a very challenging winter from a mixed group of causes, as opposed to a very challenging spring from just one cause. So we've been planning very carefully and have good plans to keep everybody skilled up as we had from wave one, and deliver our plan again if we need to, but hoping all the while that it won't be needed, because we're all pretty tired.
Very good. And then a question then for Jane. You talked about it, staff morale during the peak of the COVID crisis. Can you tell us about how you manage that?
I think during the peak, morale was high. It was great. I think we were still very much, we can, COVID-19 won't get the better of us, and it was all fine. I think it was as it was sort of ebbing a little bit and we were having less patients, that actually the tiredness and fatigue started to kick in a little bit more at that point. And that was the hardest point, I think, to manage and look after everybody. We were still as busy as we'd been, because at that point we had just as many patients. We just did not as many of them were COVID patients. That was the difference. But staff were very, very tired. We have a whole international mix of staff that work here at CUH and in critical care, and we're really, really proud of that. But obviously those staff were desperate to go back to Spain, Portugal, and see their own families, because obviously this wave has gone all the way through. And so those anxieties about, can they travel, when will travel start lifting? And then more recently, with all the travel corridors that are and aren't sort of opening and closing, has caused sort of some anxieties. We're just getting now where I think everybody has popped home and has come back, and things are starting to feel a little bit better from that point of view. Yeah.
Thank you. So 2 more questions before we've used up our hour. The time has gone extraordinarily quickly. And the first one is a technical question, so I'll ask it to Charlotte. I'll read it because I don't fully understand the question, but I'm sure that you'll know the answer. And the question is there any work in CUH and the hospital looking at the T cell response as opposed to the antibody response?
So just to explain the question a little bit so that everyone does understand, there's uncertainty at the moment about which bit of the immune system is most important in developing an immune response to COVID. For most pathogens of any sort, actually you develop antibodies to it, and it's the antibodies that stay around in your system and remember when the bug comes back, and you produce those antibodies and have an immune protection from whatever that pathogen is. We don't know whether that's the case for SARS because it's a virus that we haven't encountered before, but there's some emerging evidence that a different type of white blood cell called the T cell might be important in some papers that were published in the journal Science and the journal Cell in the last month or so. It hasn't been shown as yet where the T cells that you have developed and they're cross-reactive T cells, that people who've been exposed to other coronaviruses, such as some of the ones that cause some of the common colds, might also give you a little bit of protection from the SARS-CoV-2 virus. It's known that they react to it in a lab, but what's not been shown is that those T cells provide any immune protection as yet. So do they mean you have less severe COVID if you are exposed, or do they mean that your outcomes are better? That's work that's very much ongoing, both at the university here and across the world. So the jury is still very much out on that front.
Thanks, Charlotte. So we are gently running out of time. Before I hand over to Paul, just to say a huge thank you to Jane and to Charlotte for giving us such an extraordinary insight into the way that you've not just coped, but you've triumphed during the COVID crisis. All of us on the call as supporters, we're all humbled, we're all totally committed, and we want to carry on doing the very best we can to support you, and to thank you on behalf of everyone that's on the call today for the extraordinary work that you are doing and continuing to do. So thank you very, very much indeed. And finally, on behalf of Charlotte and Jane and myself and all the staff at the hospital and the charity, to say thank you to all the supporters on the call today for the incredible support that you've given. We know that we're going to need more support going forwards. And I think one of the extraordinary things about Addenbrooke's, the passion that we all have to make it the very best, means that when we ask for the support, it's absolutely there. And then we can translate that financial support into making things better on the front line, in the research, in the support as we move forward. So Jane and Charlotte, thank you so much for taking time out from your very busy schedules. It's been an extraordinary morning. It's been insightful, and it's been very humbling as well. So thank you both very, very much. And please say thank you to all the teams that are doing such incredible work. So I'm going to hand over now to Paul, who has a little housekeeping, and that will bring us then gently towards the end of our hours together. So thank you once again. Bye-bye. Paul.
Hello again, everyone, and thank you myself to Charlotte and Jane. What an extraordinarily humbling hour. Personally, to know that my donations have been part of making that difference we just heard about is fills me with all sorts of pride. And thank you so much, Chris, for hosting today's event. A fantastic job. We're hoping to do some more of these virtual events because they're superb and interesting, and just the best possible way for us to share with you the difference that your support makes on the ground. So I'm delighted to say that our next virtual seminar is taking place on the 4th of September, where we're really fortunate to be joined by Ashley Shaw, Addenbrooke's Medical Director, who's going to be in conversation with ACT's CEO, Shelley Thake, and they're going to be in conversation talking about this kind of senior leadership's role in rising to the challenge head on of dealing with COVID-19, and with plenty more examples of what your support has enabled. We're going to send invitations out to that in the following days, so look out for that. And we're also going to follow up with everybody that's asked questions, because there's been an awful lot of really good questions asked, so apologies we haven't been able to get around to them all. We'll also share the recording of this event, so if you want to rewatch it, if you want to share it with friends and family, please do. And then just a reminder that every donation that each of you have made, every Zoom quiz that you've persevered with over the last few months, every time you shared one of our stories on Facebook or Twitter, every time you've spoken positively about the charity of the hospital has made a difference. Everything you've heard about today is only possible because you've so kindly been with us through this journey. Thanks ever so much. See you all again very soon, and thank you once again.